Thank you so much, Stan. I want to thank the organizers for inviting me again. I was here 7 years ago for the CDC, CCAS chart joint meeting, and it is a pleasure to share the Haitian story. And my title that was suggested by Clive is Against All Odds, Haiti Leads the Way. I want to have some background on Haiti, present the situation of Haiti, because if you don't understand the situation of Haiti, you won't understand the work that is being done there. I will also talk and present the major health issues we have there and the role of GHESKIO. GHESKIO seems like to be a Korean or Chinese name, but it's before the HIV/AIDS. And if you talk about HIV/AIDS in the world, GHESKIO is the second after CDC working on HIV/AIDS, and I will present the work of GHESKIO and the perspectives. And it is important to mention that the work of GHESKIO is based on operational research and the impact we have on public health, not only in Haiti, but across the world. You may know that Haiti shares the island of Hispaniola with the Dominican Republic. We occupy the west third of Hispaniola, and in fact, Haiti means mountains. By the Tainos, the Indian Tainos, it means mountains, and there are two other names, Boyo and Quisqueya. And in 2017, our population is over 10 million inhabitants. Mostly, it's a young population. The median age is 23 years old. And the government is currently a stable government. We have had in the past 10 years a lot of instability. And looking at the life expectancy, it has improved slightly to 63.8 years due to the fact that AIDS-related death has been controlled. There's less death related to HIV/AIDS, and we have the poorest country in the Western Hemisphere. There's a lot of corruption. The country is very vulnerable to disasters. We had the earthquake, as you know, but also recently the Hurricane Matthew, who devastated the whole south of Haiti, where over 2 million inhabitants were affected. Our per capita income is very low, less than $300. Our unemployment rate is very high, 30%. And we are ranked 163rd over 168 as the Human Index Development. And the amount of money that we expend on health per habitant is very low, $13. When you compare to DR, who spend $180, or Cuba, near $800, so this is not enough. Comparing the total budget of the government, we only spent 4.4% on health expenditure. We have 5.7 physicians per habitant, and this number has increased slightly because of the Haitian-Cuban cooperation. Since 1997, Fidel Castro sent every year physicians, nurses that has helped improve, but if you take only Haitian, it would be like 2 to 3 physicians per habitant. We have had social, political instability, blind violence, kidnapping, rape, and there is the exodus of the brightest. 40% of physicians trained in Haiti for the last 20 years are working abroad. 50% of the midwives also are working abroad. And the major disease that we have currently are HIV/AIDS, 2.2% of the population. Tuberculosis, Haiti has one of the major epidemic of tuberculosis in the Americas, 194 TB cases for 100,000 inhabitants. HPV is also a major concern, causing cervical cancer and cholera outbreak only 10 months after the earthquake. When talking about public health, we need to take account about migration. Migration is an issue. Since the 60s, we had professors going to Congo, Zaire, where after the Belgium left, there have been a lot of professors from Haiti going back there. And there is a discussion about the origin of HIV, because some people think that the fact that there were teachers going to Africa, this is where they got HIV/AIDS. I will let Hakim talk about this later. We had a discussion last night on that. But also, we think the most likely cause would be mainly US tourism in the 70s that came in Haiti, and they had sex with Haitian boys, and this is one of the debate around the origin of HIV/AIDS in Haiti. We need to understand that in the 80s, a lot of Haitians were going either to the US, to Canada, but also to Dominican Republic in the Bates and all around the French islands. And currently, we have a massive departure of Haitians going to South America, either to Brazil or to Chile. When coming here the other day, there are at least 3 flights, full flights, going to Chile every day with young Haitians between 20 to 30 years old. So Haiti has been the center of the epidemic from the beginning, where Dr. Jean-William Pape, a young fellow from Cornell, who is the current general director of GHESKIO, was working at the General Hospital on diarrheal disease. And GHESKIO was the first who introduced oral radiation therapy, and that had an impact at the national level. What does GHESKIO mean? It's a Haitian study group on Kaposi, Sarcoma, and opportunistic infection. Its mission is threefold: research, many operational research, looking at health issues in Haiti, services, training, and this was mainly focused at the beginning on HIV/AIDS. We partnership with the Ministry of Health, but also with private organizations, over 100 in Haiti. We are granted public utility from the Ministry of Health since 2000, and we have had continuous support from the NIH since 1983, but also from Fogati, who has helped train our staff. We have a strong international collaboration. Those are the 2 main sites. This first one is GHESKIO, based in downtown, and as you can see, there's a big slum of 100,000 inhabitants, and I will show you later what impact this slum had on the cholera epidemic. We have developed a global health models. This has been published in JADES, and we go into the community, and it's not only a vertical program, but we address maternal child health, family planning and reproductive health care, nutrition, cancer prevention, immunization, dental and eye care, primary education and school support, job training opportunities, microfinance, vocational programs, crime factory. This shows you that we don't believe that a vertical program can help. We need to see the patient as a whole. It's not only the medical care, but you need to address other issues that the patient has. This is the synergy of the concept of the GHESKIO model. We start from a public health issue that we have in the country. We conduct the research, and the results that we have help us train staff and that will help improve patient care to have a national impact. I will give you an example. When we have the diarrheal disease in infants, this study showed that by giving oral rehydration at that time, most of the physicians in Haiti were against oral rehydration. This has helped to reduce diarrheal disease in infants by 40% within 2 years, and at the national level by 50% by the mid-90s. Groundbreaking studies. We are the first to describe chronic diarrhea, the origin and etiology. With Dr. Bernard Liotto, we described the first cases of AIDS, and it was conducted on 61 patients, and 15 had Kaposi sarcoma, 45 had OIs, and this were described in the 1978 and 1979. The average time to death was 6 months, and 80%, 85% were men. We have extensively described lesion on the skin, pulmonary, how to prevent and treat TB, and also how to prevent, treat Candida esophagitis, azoospermiosis, and cyclosporiasis. We are the first VCT in the Caribbean, opened in 1985. And for example, last year, we received over 40,000 people, new people coming for HIV testing. And of those, 7% are HIV infected. And most of them, the vast majority, 90%, come by themselves because they know the work of GHESKIO. And if you know the prevalence of HIV in Haiti, we attract 3 to 5 times the prevalence. The prevalence is 2.2, and we have up to 10% on some point of VCTs. We have shown also the association between HIV and tuberculosis. We have shown the fact that if you do INH prophylaxis, it helps prevent tuberculosis, primary tuberculosis, but also prevent the evolution toward AIDS. And at that time, in the world, they were using AZT, and since we could not afford AZT, we called INH the AZT of the poor. We have shown also that the longer you give INH, the best it is to prevent. It is a retrospective study with all the limitations that we know, but already we knew that if you give, the longer you give INH, better it is for the patient on the recurrence. For example, those patients receive INH for 6 months, the second column between 12 months and 24 months, and the third column between 24 and 36 months. And this is the median time between when you stop the INH and the recurrence of TB. So you see, the longer you give INH, the recurrence occurs later. We also showed that TB recurrence was more occurring in the HIV positive than the HIV negative. And when you give INH to a patient infected to HIV, it can prevent the recurrence of tuberculosis. This was my thesis of MPH, showing that the prevalence of MDR TB is very high when you already have tuberculosis, but what we didn't know was the association between HIV and MDR TB, showing that 3.2, the HIV infected were 3 times higher at risk when they had HIV and they had MDR TB. And from that study, WHO accepted to fund GHESKIO to have an MDR TB hospital. We showed also the epidemiology and the definitive treatment of prophylaxis for azoospermiosis and cyclosporiasis. But also, our PTM-TCT program is very strong. Historically, we went from 30% of HIV transmission, and now we're targeting elimination. As Mo has said yesterday, we are 1.2% the past 2 years. We are also conducting with the Ministry of Health a way to eliminate congenital syphilis. We have conducted with WHO the evaluation of rapid tests, and these tests will be expanded nationally. The last time I came here, I showed the benefit of starting early ART. At that time, the norm was 350 of CD4 cells. We have shown that when we start ART very early, we had 4 times less death and 2 times less TB. Since that time, it has evolved to 500, and now it is universal access that we have also in Haiti. But very early, we have shown the benefit of early ART. We have conducted a retrospective study at 1 year, 5 years, and 10 years of the first cohort of patients that were enrolled on ART in 2003, showing that the survival rate at 1 year is 82%, at 5 years, 75%, and at 10 years, 70%. We are maybe the only cohort in the Caribbean showing the profile of those 10 years patients that have been followed up. The objective of the study was to describe the 10-year follow-up and outcomes of this first cohort, and you need to bear in mind that it is in the context of the massive earthquake, the cholera epidemic, but also political instability. What have we found? This curve, the Kaplan-Meier, shows you that, first of all, the patients were dying very early, between 0 and 6 months. And we have 75, around 70% of survival, but at the end, a total of 482% at 10 years were alive. 27 died, and 13% were lost to follow up, and 71 were transferred. But what is important also is to compare when the people are dying, and we see that clearly the first 6 months, this is where we need to put the maximum impact on retention. Otherwise, when they pass that threshold, they are more likely to stay into care. And this is why in our clinic we have set up a way, prioritize the way, so when they come, they don't wait time when they are between 0 and 6 months. These are the characteristics of the 10 years survivors. They are mostly females, 58%. The age median is 49, and the median weight for the female 64 kilograms and the male 70 kilograms. The last known value of CD4 is 535, and a lot of TB and adherents, half of them are adherents for more than 90%, and 1/4 are receiving the second-line regimen. What we were not used is to the non-communicable disease, which is very new for our clinical staff. 60% have cardiovascular disease, 37% are chronic obstructive pulmonary disease, 1% diabetes, and 4 cases had more than 1 non-communicable disease. This has led us to learn that the success of ART in our programs showed half of them are alive 10 years after starting treatment. The highest rate of death and loss to follow-up occur in the first 6 months after treatment, and we have a high prevalence of non-communicable disease among survivors, indicating the needs for ongoing training and integrating this kind of training into our program. Recently, we have developed innovative way to improve retention, and the first was the same-day NIH clinical trial, and the second is the rapid pathway. This clinical trial showed clearly that the patients that were enrolled the same day were doing better, much better, less death, more are alive and in care. And looking at viral load, 54% compared to 42% had less than 50 copies. And when you're looking at less than 1,000 copies, once again, those who were enrolled in the same day were doing much better with significant p-value. The rapid pathway was introduced 3 or 4 years ago because we have a lot of patients coming at our clinic. We have over 11,000 patients, and this caused a lot of work for the staff. So what we did is to have a nurse and a field worker identifying those who were coming at the clinic the day after. They will call them, and if they feel fine, they will go into this rapid pathway. It's like a red carpet treatment. And when the patient comes in the morning, they'll verify the patient is well, and they don't have to see the physician, and the nurse will provide the medication in half an hour would go. This allows time for the physician to see more complicated cases, and this is a way to go faster. And if there's an issue, the nurse would just refer those patients to the physician. We conduct all those research based on ethics, and we are the first ethics committee in Haiti in 1984. And also we were instrumental in having a national bioethics committee in 2003 when we were to conduct HIV vaccine trials. We are the largest referral training for postgraduate in Haiti, and we receive lab technicians, social workers, nurses, and you see the numbers. But one thing also we capitalize is on religious and community leaders. As you know, most of Haitians are Catholic, but even though they would go to the voodoo priest, and it is important to work with this kind of population, those leaders, because the voodoo has a lot of influence in the population. When someone is sick, they would not go to the medical for support first. They will go to the voodoo priest first, and we will see later the impact on HIV/AIDS. We have 3 kind of specialized training and MPH since 2005 that we conduct with GHESKIO University. We have a nurse practitioner program. As I showed you earlier, the physician, the nurses are leaving the country, and it was important to identify a category of personnel to be trained and to be able to stay in the country. They receive a 1-year training. Half is theoretical with GHESKIO and half with GHESKIO, which is practical. And when they return, we make sure that they stay in the country, and this is how we try to keep our staff into the country. We have also a collaboration with the National Laboratory to help train technicians, lab technicians. We are the largest network of HIV in Haiti. As of June, over 83,000 patients were on ART in Haiti, and 1/3 in the GHESKIO network. And on the 2 sites of GHESKIO, over 12,000 patients on ART. This is very important because all the sites are well distributed in Haiti, and you can see the numbers over time increasing, red at the national level and in blue in the GHESKIO network. And at any point of time, we are 1/3 of the total patients on ART, and this has helped reduce the prevalence from 6.2 in 1993 to 2.2 in 2015. Currently, we are conducting a new HIV prevalence study in Haiti, and we hope that it will reduce again. This is our multidisciplinary team doing supervision, but also training on site, and this has helped improve the quality of care on those sites. We are also the main TB treatment. We received last year over 2,000, nearly 3,000, and the newest received only 500. And this has been conducted through what we call active case finding. With 80 community health workers, we go and screen the slums and asking them if they have a chronic cough. All those who have chronic cough come to GHESKIO, and once again, we have been able to identify a fair amount, 37%, who are also HIV infected. We have our BSL3 lab, where we can conduct viral load, but also resistance for MDR-TB. This are the numbers of routine lab tests, and we have had the support of Valerie and others to help improve our lab. And our MDR-TB treatment is going very well, and we have good numbers on terms of survivals. 80% survival rate compared to 50% worldwide. So how did we do that? Is to have what we call community health workers going twice a day using motorcycles and GPS to make sure that the patient is taking the drugs. Those drugs are very toxic, and mostly the patient would not like to take the drugs. So we make sure that the field worker take the picture of the patient taking the drugs. And we have the GPS that we download. For two reasons: the patient doesn't want to take the drugs, and the field workers, as you know, sometimes they take the money and they don't go to see the patient. So we want to have a documentation to make sure that the patient is taking the drug, and also that the vehicle is going to the... This is GHESKIO before the earthquake, as you can see, very green, and after the earthquake, where we have 10,000 inhabitants going into our compound. We have had major damages, and we had 10 months after due to lack of sanitation at the cholera. This is the Big Slum, two Big Slum, City of God internal city, where 100,000 inhabitants are most likely at risk for cholera. We have conducted a vaccine campaign where we have given, this is our CTC, our cholera treatment center, but for the vaccine, we went into the community and vaccinated 50,000. And as of now, we have no cases of cholera in this community. We have had the support of CDC to prepare, to have a chlorine factory, and this is where we prepare and distribute chlorine to the community. Nutrition is very important in Haiti, and we have used the fortified peanut butter in children and showed that by giving the peanut butter, it reduced stunting and wasting by 70%. Cancer is a very important disease, cervical cancer, and we have identified the main subtypes, 16 as you could imagine, 18 on both HIV and HIV negative individuals. And then we conducted last year a HPV vaccination among young girls 9 to 14 years, and they received, 92% received the 2 doses at the community approach, and at the school 98% with an overall of 94%. Global health is a new approach. We need to take account not giving them access to microcredit. We have a primary school and a vocational school. This school is called the Prince Albert, and Prince Albert of Monaco, he came and donated that school with over 300 students. And those students, what is very important, they went to the state exam, and all of those passed the exam, and the 3 laureates were from that school. And we offer youth support and also vocational training on culinary, but also on woodworks. And those are the arts work, and if you come to Haiti, you can order and have those very beautiful artwork. Our priority for the next year is to focus on multi-resistant tuberculosis, nutrition on mother, infant, and also global health. How did we do that? We know that what doesn't kill you will make you stronger, right? And against all odds, Haiti leads the way by developing effective public health models, by describing the natural history of HIV, implemented and evaluating innovative models for the delivery of heart. But the further step now is to develop strategy to end the HIV epidemic. We will reinforce VCT HIV prevention, mostly among commercial sex workers, MSM adolescents. We are the only adolescent clinic in Haiti, conducting clinical trials to improve MDR-TB drugs, aiming at the control of cervical cancer and contributing to the cholera epidemic. How to be positive and successful in Haiti? First of all, you have to have strong leadership. This we have through Dr. Jean-William Pat and Marie-Marcel Deschamps, who is deputy director, but also it's a teamwork. Those are the main actors working at GHESKIO, and we have had the support of international collaborators, Warren Johnson from Cornell, Dan Fitzgerald from Cornell, Peter Wright from Dartmouth, Alain Milliot from France, and we acknowledge our volunteers, our patients, our dedicated staff, our international and national collaborators, our donors. Thank you very much.
It's absolutely terrific to see the most resource-limited country in the Caribbean doing such fine and inspiring work. Thank you very much. I'm sure there are questions and people will come up to the mic, but let me just start by asking, the rapid pathway makes so much sense. We've seen studies in the US, Europe, now Haiti. Where do you think the obstacles will be to ramping this up for it to be absolutely routine in all of Haiti? What are the obstacles at the ministry level, at the logistical level, at the economic level?
Okay, this was a very important issue for us. Patients were asking to reduce the waiting time, and we needed to find a way. The second issue was reduce funding. If you want to reduce time, you would have to have adequate staffing. There was no way to have more funding. So we decided to have this kind of method strategy, and where it is working very well, and this is being extended to our network. We have 26 sites that we supervise, and it is the GHESKIO network. Those sites are supported through PEPFAR and Global Fund, and there is no there is no site that is not willing to do it. The only obstacle is logistics. You need to find someone dedicated to do that only, and when you have high volumes, sometimes it's kind of challenging, but otherwise it's working perfectly at our two sites, and it's the way to go further.
Brendan B., thank you very much, Patrice. Having had the privilege of visiting GHESKIO more than once, I see a lot that you have not been able to mention in your short presentation. You know, the planning, the dedication. One short story I remember just after the earthquake, which incidentally we felt a little bit of it in Kingston at the time. I was taking part in a webinar, and we felt it we felt the floor shake. But not long after that, I phoned Bill Papp and I said, "How are you?" And he said, "We've just had an aftershock, and at the same time, a vehicle has rolled up with some new supplies for us." He said that in the same breath, you know, which said to me the determination of the man. You summarized the benefits of ARV in some of your slides, and that's undoubted, but you also paint a picture that you don't just give ARVs to your patients, and that's what has made the difference in their survival. So your holistic approach is something that all of us can learn from and try to practice in our different settings. Would you comment on that?
Yes, this is why I took some minutes to present the background situation of Haiti. The situation is very difficult, and if you just address the ART issue, you're not doing much. And I feel it is the way that donors are trying to go into. They will only pay for the drugs, and you make sure that the patient take the drugs. I told you yesterday that most of the patients will come to the clinic and say, "Doctor, I have a meal today." And what we do with Global Fund is to make sure for the 6 first months, we provide them nutritional kits that they could go home and make sure that they have the food at home for the 6 months. We have shown that when they pass the first 6 months, they are more likely to stay into care. Now we have looking onto patients that doesn't come back, and we have a questionnaire trying to see why they're not coming back. And we have psychologists looking into this, and the first results are showing that they are moving. The migration is a main factor. So now we're trying to link them to the other side. But once again, discrimination and stigma is another issue because they don't want to take the job to see the patient, to have the scheduled visit near where they live, because they don't want that people around the neighborhood would know. And even if they are in the city, they prefer to have take a cab transportation from Lekai, which is 3 hours from Port-au-Prince. So these are logistical issues that you need to take into account and understand the human being and not giving the ARTs like some are suggesting.
Carmita Dublin, Barbados. Excellent presentation, Patrice, and you're doing a lot. I really could not imagine that so much was going on in Haiti. So I'm very, very impressed with your presentation.
That's only 10% of what you're doing.
All right. My 3 very quick, brief questions. I'm more focusing on the underlying empowerment, the enabling factors. All right. My first one is the movement of, as you quoted, the brightest minds. You said about 40% of your doctors are moving, 50% of the nurses. And I'm wondering if the government is doing anything to try to retain these bright minds in Haiti. I know recently, I don't know how it worked, but I just heard on the news that Guyana was putting some measures in place to try to keep their bright minds there. And my second one is community mobilization. I know Professor Landis mentioned yesterday the difficulty in behavioral change and trying to get persons, to change their behavior. But are you looking at a lot of community empowerment, mobilization, and involvement in a lot of the work that you're doing? You mentioned about the voodoo, and for years we've been hearing that some of the reasons why Haiti is remaining the way they are is because of those strong traditions and beliefs. So we're hoping if you can have some type of change, we can see movement. And the last one is corruption. For years, we've been hearing about all the corruption in Haiti, the drugs not reaching the people. Even when I was at the United Nations, a lot of the help and aid that would have gone into Haiti never really reached the intended targets. So I'm wondering too if anything is being done to curb this corruption. And all of these enabling factors would impact on all of the great work that you're doing.
Yes, 3 excellent questions. And the first is exodus of the brightest. Is the government doing anything? I took some minutes to show you the slides of migration. And this is not new. This was caused by instability at the national level. And one thing we need to understand, anything that affects Haiti will affect other countries, other islands in the Caribbean, and we need to think globally and act locally. So it's not having a vertical program in your country and forgetting about the others. We need to really have a network around our islands and develop strategies together. Why are those people leaving the countries? In the past 10 years, it was mainly political. Nowadays, it's more economical. There is very few opportunities. And when you're looking about the young who finish high school, there is no opportunity of working, no opportunity to go to any kind of school. So they kind of block and they have to go elsewhere. So if we don't have a global plan and helping the government of Haiti, and fortunately we have a new government that seems, quote unquote, to be very progressive. We will wait for more actions, but I think we are in the good way. talking about the political and government. Corruption is not only seen in Haiti, but it is a mixture of the donors, international support, and locals. So it's like a mafia, and everyone try to get the gain into this confusion situation. And local have led this kind of situation happen, but also it is fully fueled by international also. And the second question was community. What I didn't show you is the role of community health workers now. We are also training what we call the community health workers, polyvalent, which go into the community, not only for HIV/AIDS, but also for TB, for malaria, or for reproductive health. So they go into the community and can offer a package of services.
Sorry, Patrice, if I could just explain. I'm actually not talking about what help you're doing in the community, but how the community is coming together to help themselves to make a difference.
Okay, in that point of view, the community was not well organized. Talking about cultural, Haitian tends to be very selfish. Only when there is a catastrophe, we come together. And now they're organizing better and using the community leaders that we train. They take the lead and organize the community so we can have a better interaction between us and the community. I remember a year ago, the Minister of Health of Haiti inaugurating the MDR TB hospital, asked Dr. Pap to have one GHESKIO at each of the departmental level, and if we could do so, Haiti would get a step further.
And you're probably right there.
Let's keep 2 quick questions and
Yes.
quick answers. Thank you.
Yeah, thank you very much for a wonderful presentation as always. And my question is actually pretty simple because I didn't see in your last slide where you talked about, the initiatives for the future, any mention about mother-to-child transmission, prevention of mother-to-child transmission. Maybe that's part of the 10% that you didn't actually include in your final breakdown. But I think this is an area that, there's a lot of potential for that. So could you comment on that?
Yes, the second point is nutrition, but also mother and infant.
Yeah.
So we link all those together because all nutritional issues has to go through the family, and the mother is the pillar of our society. Our society is based where the mother is very key instrumental for the well-being of the children, and this is why we have a special unit looking between the pair, mother and infant.
Jean Thomas, so I'm very proud that you did your study in Quebec. And I think that all the brightest have not left Haiti. So I think that Haiti is very lucky to have people like you. I would like to hear you about the law that the Senate wants to pass about MSM and how it could have an impact on the prevention in this high-risk community.
Very quickly, Thomas, MSM are very discriminated in Haiti and not well tolerated. And if you look at the issue of AIDS as a whole, remember that it was called the 4H disease. And why we had Haitian, because migrants who were asked in Miami if they were IV drug users, if they were looking at risk factors, and they didn't want to disclose that they were either bisexual or homosexual. And this is where we had the Haitian as a risk factor. Recently, the Senate just passed a law because there were association of MSM gays trying to promote gay marriages, and the Senate prohibited to that law, and this will have an impact on the MSM gay community because they will be hiding more and more, and it will be more difficult for HIV programs to get into their communities, and this kind of law or homophobia won't help HIV programs in Haiti.